This is Lecture 12, Community Psychology and Health Psychology. Reminders and announcements. So the readings this week, I'm going to combine the last 2 weeks of readings into one lecture so that you guys have a little bit longer to complete the material, and as well I've abbreviated the required readings, so it's just mostly a few pages from each of the chapters on community psych, health psych, and forensic psychology. Homework 12 will be due on Sunday the 16th, so that's the Sunday of finals, the Sunday after finals week at 11 p.m., the usual time. Again, there's no lecture 13 or homework 13, so this is it. And exam 3 will post next Monday, the 10th, and will be due on the same day as homework 12. So make sure you budget your time so that you have time to do both. I can offer an extension, a one-day extension for exam 3. So the grades are due on the 18th, which is Tuesday. And if anyone happens to need that extra day, that Monday to do the exam, contact me as soon as possible, and I'll be happy to issue a one-day extension for the exam. So Chapter 16, Community Psychology. Community psychology is a perspective on psychological treatment that emphasizes the role of environmental forces in creating and also alleviating problems. So in community psychology, problems are caused, or at least under this perspective, problems are caused due to an interaction over time between the individual, their social setting, and then other systems like organizations, governments, schools, etc., that all influence each other. And problems can be defined at many levels. They can be defined at the social setting level, the individual level, or we'll go into a number of different levels that problems can exist in. But a particular emphasis is placed on the organizational level of analysis, such as the community or the neighborhood. Community psychology is practiced not usually in clinics, but more out in the field, so in the organizations in the community, or in the social context that may be believed to be causing the issue or could be a source of intervention. And services are planned for more than just the people who seek help. It's the entire community and anyone who is at risk in that community. That's the target of the intervention. An emphasis is placed on the prevention of problems rather than treating existing problems. And the actual interventions are often carried out by non-psychologists, non-professionals, paraprofessionals, and even like self-help programs. A bit of historical perspective on the situation in which community psychology as a field developed. In 1955, there was a joint commission on mental health and illness, and the results of this joint commission indicated that it would be helpful to develop community mental health centers, and this was in contrast to the existing model of dealing with people with mental illness, which was essentially throw them into a psychiatric hospital, which at the time looked quite different than our current psychiatric hospitals, so there's still could be identified as a number of problems in current psychiatric hospitals, but back in the 50s they were really much more problematic. There was much more abuse. It was less treatment. It was more kind of like warehousing of people. And so the Joint Commission encouraged a reduction of patients in those psychiatric hospitals and wanted to move those patients to community centers. So a number of years later, the Community Mental Health Act, which was put forth by JFK in 1963, funded construction of these mental health centers in the community, and these mental health centers provided comprehensive services to hopefully prevent the warehousing of patients in the psychiatric hospitals. The Community Mental Health Act also promoted early detection and had significant support from the American Psychological Association. 2 years later, there was a convention in Massachusetts, and this was sort of the official birth of community psychology. The American Journal of Community Psychology was formed, and there was an APA division that was created at that time. In the 70s, there was an expansion with more community psychology journals and community-focused textbooks. In 77, there were a number of writers, including Julian Rappaport, who solidified the community psychology perspective in books and journal articles. And one way that it was conceptualized is community psychology is not so much a set of techniques, but a way of looking at the treatment of psychological issues, in which there are several important components, one of which is cultural relativity. Diversity is important to consider, and then ecology is vitally important to the community psychology perspective, ecology being the relative fit between a person and their environment. 3 sets of concerns would define the community psychology perspective, and this was the development of human resources, political activity, so activism, and scientific activity. In the 1980s, the growth of community psychology and these community health centers was cut short by some decisions that were made during the Reagan administration. There were funding cuts and fragmentation of community mental health centers, which led to a decline in community mental health centers. And this essentially continued until the 2000s during the Obama administration. There was widely publicized healthcare reform, which has led to a partial revival of an evidence-based community psychology approach with an emphasis on prevention. And this is reflected in the way that resources are allocated from the government and as well in funding. So research funding on prevention is encouraged, or at least was encouraged during the Obama administration. From the genesis of community psychology and onward, there were a number of factors that contributed to this perspective. There was a desire, as I mentioned earlier, for alternatives to the current at the time, so in the 1950s, treatment facilities, which was essentially just hospitalization. Treatment facilities weren't cost effective, they weren't very efficient, and there was kind of a custodial standpoint where people were sort of almost sort of prisoners in these facilities. Populations of hospitals were reducing due to the introduction of psychotropic medications such as antipsychotics and more liberal discharge policies. So people were being discharged when they maybe weren't quite as far in their treatment as maybe in the past. As well, there was a lack of trained professionals. Demand was higher than availability of trained professionals, people who could do therapy, and there was an increase in prevention efforts, which could be done, implemented by people who weren't necessarily trained in therapy. Another contributing factor was that people were questioning psychotherapy at that time. As we talked about previously, there were some studies coming out that questioned whether psychotherapy was efficient and efficacious, and whether the cost of psychotherapy could really justify using it as a treatment. And this, at the time, they were looking at psychotherapeutic techniques that were more intensive in terms of time and money, and were happening over a longer period of time. As well, the medical model was falling out of favor. Medical model meaning looking at mental illness as purely physical or medical disorder. So this was kind of consistent with the spirit of 1960s activism, where traditional models and beliefs were being questioned in general. Around this time, in the 50s and 60s and moving on toward the 70s, there was also a greater awareness of environmental factors contributing to psychological problems. So things like poverty and discrimination, and even environmental pollution, overcrowding, limited educational opportunities for some people, and sexism and racism. People were starting to understand that this can contribute to psychological problems. There's a way of looking at all of the factors in a person's life that influences their psychological functioning, and it's called ecological levels of analysis. And in this model, there is an interdependence in the different levels of the system. So the kind of inside layer is the individual level, and this is the relationship between the individual and their environment. And then one step up is microsystems, where the individual engages with other people in their environment. And then organizations, so the individual is interacting with a school or religious organization, their workplace. One step up from that is localities, which is the entire community, which has these sets of microsystems and organizations. And then macrosystems is the largest level, and this is entire societies and cultures, also organizations that are larger, such as the federal government. And this is how the model looks. It's these systems embedded within the larger systems. The principles of ecology are that every ecosystem consists of multiple independent parts, and those parts are independent, but they also interact. So they're understood by examining the resources that are used and how these resources are important to functioning. So sometimes we understand an ecosystem when certain resources are not available. So when there's not good schooling, or there's a food desert, something like that, we start to understand how those aspects of the ecosystem are important to the functioning. We know that individuals adapt to their ecosystem, and indeed some people don't adapt well to certain ecosystems, and this can cause psychological problems. And we know that ecosystems are dynamic, they are constantly changing. The next section is chapter 17, Health Psychology. In the health psychology chapter, we're only going to be covering briefly what is health psychology, and then the intervention section, which is just a few pages. So broadly, health psychology is looking at how physical health issues are influenced by and also influence behavioral and lifestyle choices. And health psychology is a subset of behavioral medicine. So behavioral medicine is the integration of behavioral sciences and medicine, and is a scientific investigation of health. And health psychology is sort of psychology's role within behavioral medicine, especially psychology's role as a science and as an intervention. And health psychology aims to promote and maintain health behaviors in a kind of whole health perspective, and also looks at illness prevention. So prevention is a really large part of health psychology, preventing behaviors that lead to poor physical health outcomes. We're not going to cover that in this section, but there is some material about that in your chapter, if you're in the chapter of your book, if you're interested. One class of interventions within health psychology is based on classical or Pavlovian conditioning, which we've talked about in previous chapters. Within health psychology, we're looking at how emotional reactions can be paired with conditioned physical issues, and this response is based on classical conditioning principles. And so an example of this would be if a client had a traumatic experience, say in a grocery store. Maybe she witnessed a robbery in a grocery store. Every time she goes into the grocery store, she might get an anxiety response, which might be paired with a physical response, such as hives or nausea. So to intervene in these occasions in which somebody has a physical response to psychological stressors, a client is first given psychoeducation about the connection between the mind and the body, and also the client and the therapist work together to collect information about when these physical responses occur. So for example, the client I mentioned previously who has hives every time she gets into a grocery store, the client and therapist would have worked together to figure out that the hives occur whenever she's in a grocery store, and this would have allowed them to trace it back to maybe a traumatic event that happened in the grocery store, or social anxiety that flares up when she's in a grocery store. Then the therapist and client work to extinguish the response or remove that association, that conditioned association between the environment and the physical reaction. This can happen through systematic desensitization or also exposure therapy coupled with relaxation training for the client. There are also interventions within the framework of operant conditioning that can be helpful in dealing with health behaviors. So operant conditioning framework can be used to increase positive health behaviors or also decrease negative health behaviors. The book had a nice example about someone who suffers from pain issues. So pain is something we see a lot in the clinic, in any clinic, especially kind of in the midst of the opioid crisis. There's increased interest in psychological interventions to deal with pain as opposed to just using pain medication. And pain is something that has a physical, it often has a very medical or biological cause, but there are psychological factors in how somebody appraises their pain and the degree to which pain causes distress in a person's life. And so, for example, a person may have a sort of learned response that the more that they express pain or talk about their pain, the more they receive caring behaviors from the people around them. And a therapist and a client, and also the therapist and sort of people in the client's family or inner circle, can work together to decrease the reinforcers of caring behavior when somebody complains about pain, for example. So this shouldn't mean that the people around the client stop showing caring behaviors toward the person in pain, but maybe the caring behaviors are not contingent on that person expressing pain, just to decrease that sort of like reinforcement schedule. As well, the therapist and the client, or the therapist, the client, and the people around the client can create contingency contracts where there's an agreement about expected behaviors and consequences. So this might work well in the context of like smoking, for example. So there can kind of be an agreement that if a client is trying to stop smoking or stop using substances, like abstaining from substances might be reinforced by some kind of positive reward. So maybe if a person's able to abstain from tobacco or abstain from alcohol for a week, then there's some kind of meaningful reward for them at the end of the week. And this is written up in an explicit contract between the therapist and the client to make it super clear and really reinforce those behaviors. Cognitive behavioral methods are also popular for dealing with health behaviors, and there's a lot of research support for this. So cognitive behavioral therapy, as you know from previous chapters, modifies cognitions or works with people to modify cognitions and perceptions, and in this case related to health problems. There's a specific type of CBT called stress inoculation training, which helps people develop adaptive ways to deal with and conceptualize life stress. So it's building resiliency with the expectation that somebody is going to encounter stress in the future, and developing coping strategies so that the stress doesn't negatively impact their health. There's also a component of self-monitoring, a large component of self-monitoring, in which a client works with a therapist to track their health behaviors and track their psychological functioning and build awareness of how behavior impacts health, both psychological health and medical health. And also how cognitions can kind of play into negative health behaviors and psychological issues. Biofeedback has gained a lot of attention in the past few years, maybe past 10 to 20 years. In biofeedback, the client learns to control their physiological processes. So through relaxation or stress reduction techniques, people can control their heart rate, lower their heart rate, for example, lower blood pressure, and there's also certain brain waves that you can learn to behaviorally control. So there, for example, certain frequency bands of brain waves are associated with relaxation, and this can be monitored in real time. So somebody can be hooked up to EEG and see their brain waves, and there are specialized programs that kind of identify when these brain waves associated with relaxation are being exhibited, and a person can learn techniques to increase the implementation of those brain waves. Within biofeedback, generally, there is some kind of apparatus that feeds real-time health information back to the patient. So whether that's heart rate or blood pressure or brain waves. And then the patient modifies this behavior modifies their behavior or modifies their sort of relaxation level based on this information. And the idea is it's kind of real-time feedback on whether they are physiologically relaxed or physiologically in this sort of more ideal health state. And there's an example of a session if you'd like, if you follow this YouTube link. There are a lot of concerns about biofeedback. I think there was a lot of excitement about it, or there has been a lot of excitement about it, but research into biofeedback has been rather disappointing. It's not clear that biofeedback is any better than just relaxation training without the feedback, without the physiological feedback. It's high cost. You need rather advanced physiological monitoring apparatus to use it. And in general, I think it's healthy to be critical of any technique that sort of has this like fad-like interest. So there are a lot of people who stand to gain money off of training people to use biofeedback and also selling the equipment that you need for biofeedback. So I think it's healthy to be a little bit suspicious and really look at the literature when deciding if biofeedback is going to be the best intervention for a given client. And our final chapter is chapter 19, Forensic Psychology. We're going to cover the section on major activities of forensic psychologists. Forensic psychology in general is the application of psychology to the law and legal profession. Forensic psychologists have a range of responsibilities, but typically provide testimony and expertise in legal cases. So some main activities of forensic psychologists is to serve as an expert witness, to be involved in criminal and civil cases, help with domestic issues, help with protecting the rights of patients, predicting dangerousness or violence risk, psychological treatment for forensic cases, and as well consultation. But we are going to cover just 3 of these 8 activities: expert witness, criminal cases, and predicting dangerousness. You're probably familiar with the idea of an expert witness, which is someone who provides expert testimony in a court case. In the case of psychology, an expert witness would help the court to understand and evaluate evidence related to psychological functioning, and this could be psychological functioning of the defense or the prosecution, depending on the court case. They offer opinions based on psychological expertise, so typically this would be somebody with a PhD or a PsyD, sometimes as well psychiatrists. And the judge has a final decision on what expert testimony is admissible. So the judge still is deciding to what extent the expert witness can provide a certain testimony. And evidence from the expert witness should be reliable, relevant to the case, helpful for the case, and fitting for the scenario. Clinical qualifications include a high level of education and training, as I mentioned before, relevant experience. So this is definitely an expertise within psychology. Not any psychologist can sit on the stand and provide and work as an expert witness. Typically, people in forensic psychology will have at least some background in research and publication on forensic issues, a deep knowledge and application of the principle, and there are special tests and measurements, so special assessments that are used in a forensic setting, such as tests of malingering or like falsifying or exaggerating symptoms. We have some ways in forensic psychology of not 100% determining, but indicating whether somebody may be exaggerating reported psychological symptoms. A psychologist serving as an expert witness has to be prepared for cross-examination, which can be rather aggressive. So the psychologist or providing expert witness should be prepared, should be very honest and admit any weaknesses in the assessments, in psychology's ability to predict violence, for example. They shouldn't try to overstate the ability of forensic psychology to predict people's behavior or explain people's behavior. They should talk in meaningful terms, so not in psychobabble, but in terms that a regular person without psychological training could understand. Listen carefully for the wording of questions to answer the questions precisely. And often forensic psychologists serving as expert witnesses find that there's a lot of pressure to speak quickly and immediately and kind of have an answer on hand. But it's recommended that a forensic psychologist serving as an expert witness takes time to think and really is careful about the words that they choose. Psychologists working with criminal cases will often find themselves in cases where it's trying to be determined if an individual was so mentally ill at the time of committing a crime that they may not be responsible for that crime. And this would be called an insanity plea, or NGRI, not guilty by reason of insanity. The criteria for this varies by state, but for the most part it means that a person was committed a crime but may not have been in a place to understand that what they were doing was wrong, or not even knowing what they were doing. So I worked in Hawaii State Hospital, which is in Kaneohe, as a practicum student for a year, and they have a lot of cases there. It's technically a state psychiatric inpatient hospital, but all the forensic cases get sent there, so all of the not guilty by reason of insanity cases will end up in Hawaii State Hospital. So a lot of times it's people who were in a state of such active psychosis, for example, that they didn't know what they were doing, or they had such strong delusional content that they were working within that delusional content and weren't in touch with reality. So sometimes people will think that to save the world they have to kill a certain person, so there may be an attempted murder charge, but this person was operating outside of reality. Other things, people might have strong delusions about members of their family trying to kill them, or a range of reasons. So it's not as common as the media would have you think that somebody in active stages of psychosis or other serious mental illness try to hurt other people, but in those cases there is a mechanism within our legal system to not necessarily hold that person responsible for what they've done. There's a pretty low success rate in general of NGRI, although I've heard that Hawaii has a relatively higher rate of allowing NGRI pleas. The burden of proof in this case is on the accused, so it's necessary for the defense to determine, or the defense to prove that the person was not guilty by reason of insanity. This is usually done through a series of psychological tests performed by an expert. In the state of Hawaii, a person who wants to enter an NGRI has to go through 3 assessors. So they have to be assessed by 3 individuals, forensic psychologists or psychiatrists who are experts on assessing people for insanity or competency to stand trial, which I'll get to next. Importantly, insanity plea is a legal term. It's not medical or psychological, so there's no diagnosis of insanity. Insanity is not a word that we use in psychology, or at least not with any kind of meaning. The term insanity has no psychological validity or power in the field of psychology. So competency to stand trial is another aspect of the legal system in dealing with people with especially severe mental illness, and this is based on the fact that if a person is going to stand trial for a crime that they have allegedly committed, they need to be in a mental state where they can participate in their legal defense. So they need to understand the charges against them, understand the role of the judge, understand the role of their lawyer, understand kind of the decisions that they have. So if they want be in a mental state where they could decide to take a plea deal and not be under coercion. So often, this is also really common in Hawaii State Hospital, that somebody is receiving inpatient psychological treatment because they need to get to a place where they're able to understand these charges against them. And a lot of times that is, again, someone who's experiencing psychosis and needs to be stabilized to the point where they can get back in touch with reality enough to understand what's going on and be able to participate in their legal defense. It is more common than an insanity plea. Often people who are undergoing treatment in order to regain competency to stand trial are going to be entering NGRI pleas. And there are assessments for determining if somebody's competent to stand trial, which is essentially a lot of times just kind of asking people if they, like, what are the function of the different people in the courtroom. Somebody who is experiencing psychosis, and even somebody who's experiencing delusions and hallucinations, can still be competent to stand trial. They just need to understand enough about the courtroom to participate. And so there are interventions, for example, even like classes at Hawaii State Hospital, teaching people about the courtroom and about the different, about their place in the legal system in order to help them regain competency. The final role of forensic psychologists that we're going to talk about is predicting dangerousness, which typically means predicting violence risk in patients. So we talked in the last section about the Tarasoff case, in which a young man had threatened that he was going to kill his girlfriend, and the therapist was found to have not responded adequately to this threat. And this is a problem in general because psychologists do have this responsibility to inform if they think that there's a risk for violence and there are a high risk for violence in their clients. How do we know what a high risk is? Violence risk is highly overpredicted in people with psychological problems, especially certain psychological problems like autism and psychosis or schizophrenia. In part, this is due to sensationalization by the media. In part, it's due to the confounding factors of mental illness and substance use. So substance use does increase people's risk for violence. There are assessments that exist that help us to predict the likelihood of violence risk, but notably training is required to do these assessments. So it is often the role of a forensic psychologist to provide, to be an expert in determining whether somebody may be at risk for violence. So there are some guidelines for accurate violence prediction. One of the guidelines is that different violent acts have different predictors. So like aggravated assault in the context of a robbery may have different predictors than violent sexual assault, for example. The single best predictor of future behavior is past behavior. And this is a basic psychological principle that has been found even outside of the field of violence risk. This is just a kind of a psychological truism that somebody's historical data on an individual client is the best means by which to predict how they might act in the future, which isn't to say that people should always be held, should never be able to kind of get past things that they've done when they were younger or in their past, but in terms of just actuarial prediction of what might happen in the future, we know this to be a good predictor. As well, certain circumstances or settings or client characteristics are known to predict violent behavior. Again, by no means does this mean that a person is going to be violent because they have one or more of these characteristics. It's just characteristics that are more associated with violence. So one, as I mentioned before, is substance abuse, which is a big predictor. So people lose their inhibitions and may be more emotional when they're using substances. So people who may not otherwise be at high risk for violence can certainly be at a higher risk for violence when substance is involved. Male gender is associated with a higher risk for violence, which again by no means says that all males are violent. It's just statistically males are a little bit more likely, a bit more likely to be violent, as well as antisocial personality traits such as callousness and lack of remorse. It's important to be, as I have kind of already said, important to be careful using demographic information to make assumptions about people in terms of violence risk. So these are just things that can be taken into consideration, but they can also be abused. So for example, violence is over-predicted in clinical settings, and we know as well in beyond clinical settings, such as in a police force, violence is over-predicted in Black or African American men. It appears to also be under-predicted in white women. So people don't expect women in general to be violent. This is more so the case for white women, and may have created an unfair bias in terms of different people with different demographic factors being assumed to be more violent. Okay, and that's it. We are done with the content of this course right now. I really enjoyed having you guys in class, especially the thoughtful responses to homework. A lot of you really took the material and ran with it and came up with some fascinating ideas and thoughts and questions. So I really enjoyed that, and I kind of wish this could have even been an in-person course. I wish you could have benefited from some of the feedback and questions of some of your fellow students, but that's just the nature of an online class. If anyone's considering applying for graduate school in clinical psychology, there is an appendix in your book with some advice. That's decent advice. It's starting on page 562. I'm also very happy to connect anyone with additional resources. There are some websites that can be really helpful, as well as people in the field who make decisions about clinical psychology graduate admissions. So I'd be really happy to connect anyone. As well, if you're considering a field outside of clinical psychology, but somewhat related, where I might have colleagues or friends, such as psychiatry, social work, psychiatric nursing, I would be very happy to connect you with colleagues who can offer advice in your career moving forward.